السلام عليكم. صرنا زمان صورتش في فيديو صورته بس لسه ما نزلته يعني مش عارف امتى حنزله، ما فيش عندي وقت صراحة. بس هذا الفيديو بدي اصوره، مش حيكون فيه اشي، بس بريزنتيشن تبع اليوم. المادة basic pharmacology عن drug distribution، كيف الجسم بوزع الدواء. بس حصور لكم اياه وتشوفوه، وان شاء الله تنبسطوا وتستفيدوا في البرزنتيشن. ولو في اي سؤال اكتبوه تحت، اكتبوه في هذاك عند الاسئله يعني. وسوي لايك وشير وسبسكرايب. السلام عليكم. So today our presentation topic about drug distribution. So under the title of where do the drug go, the journey of drug distribution in the body. So this is the table of contents, the outline we will speak about. First, introduction, definition and importance, factors affecting the drug distribution, volume of distribution, special compartments, redistribution and clinical implication, drug distribution and interaction, emerging concept, and finally our conclusion of today's presentation. So our today quote is, in pharmacology, it's not enough to deliver the message. You have to make sure it reaches the right address. So this is our quote for today. First, I have this video, it's 2 minutes video, so we may start with the video.
When a drug enters the body, it doesn't simply vanish into action. It embarks on a journey, a complex path shaped by chemistry, physiology, and time. But not all drugs travel the same route. In this short film, we follow 3 very different drugs as they take 3 very different journeys through the human body. Each one tells a story of barriers, binding, and biological destinations. Meet gentamicin, a hydrophilic antibiotic. It doesn't like fat, doesn't enter cells easily, and definitely avoids long trips. Once injected, gentamicin quickly finds itself in the plasma, and it mostly stays there. It doesn't venture far into tissues. It can't cross the blood-brain barrier. It can't slip into fat. It's a local commuter, traveling through extracellular fluid, reaching sites like the kidney or the urinary tract, and then exiting via renal elimination. Its journey is fast, focused, and functional, but limited. Now boarding phenytoin, an anti-epileptic with more sophisticated tastes. It's lipophilic, enough to reach the brain. But it prefers to travel with company. About 90% of it binds tightly to plasma proteins like albumin. Only the small, unbound fraction is free to act, meaning its journey depends heavily on protein availability. In patients with low albumin, phenytoin's free levels can rise unexpectedly, a critical point in clinical dosing. Phenytoin crosses the blood-brain barrier and reaches its target, but only after navigating a tightly controlled path. Finally, we meet amiodarone, the adventurer, the drug with a passport full of tissue stamps. This lipophilic antiarrhythmic doesn't just travel, it settles. It distributes widely into fatty tissues, the liver, the lungs, even the thyroid. It's absorbed slowly, released slowly, and can linger in the body for weeks, even after the last dose. Its volume of distribution is massive, more than 60 liters per kilogram. That means it doesn't really stay in the plasma at all. Instead, it builds up in distant places, storing potential therapeutic effects and side effects. 3 drugs, 3 journeys, 3 lessons in pharmacokinetics. From the fast and focused gentamicin, to the protein-bound pathway of phenytoin, to the deep-diving distribution of amiodarone. Each drug reminds us that understanding distribution is not optional, it's essential, because in the end where a drug goes, determines what it does. Drug distribution, not just where but why.
Introducing us 3 different categories of the drug, the journey of the drug in the body and how they distribute. So we will dive more into these topics and for each example of the drug. So definition and importance of drug distribution. So basically, ADME, absorption, distribution, metabolism, and excretion, describe how a drug is absorbed into the body, distributed to tissue, metabolized by the liver, and extracted from the body by urine or by feces affecting its action and distribution. So we have here a small diagram. The absorption happens into the intestine, the stomach, then metabolized into the liver, distributed in the blood flow and blood circulation, and excretion through the urinary tract. Yes, I just gym injured. So distribution. It means how the drug move and spread through the body. This depends on the drug, chemical properties, and the person's body. Basically, two main things affect the distribution: how the drug spread into on diffusion, and how it's carried by the blood and body fluid convocation. So we have three important things we have to keep it in mind: efficacy, toxicity, and dosing. So efficacy, what does it mean? Efficacy is drug distribution directly affects how much of the drug reaches the target site. Example, brain, heart, or liver. For example, as an azithromycin, it's antibiotic, may need to reach a high enough concentration in the lungs to treat respiratory infection. If it doesn't distribute well to the treat, it won't work effectively. So toxicity. Excessive drug distribution to non-target area can lead to toxicity, which is like more drug into the body with the non-target area, so may cause a poison in the basic meaning to the body. Yes. Dosing. Understanding a drug volume of distributions helps determine the appropriate dose and dosing frequency. So we have two things we have to keep in mind for volume of distribution: low volume distribution and high volume distribution. What do that mean? Means that drug stays mostly in the blood. So you may need more frequent dosing or a higher concentration to achieve therapeutic effect. For high volume of distribution means the drug distributes extensively through the tissue. So lower dose may needed to achieve the therapeutic effect, but dosing may be less frequent. So factors affecting the distribution. So we have here, why do some drugs affect the brain while others don't? So we will know more about this quote. So we have here three main properties that may affect the drug distribution: physiochemical properties of the drug, physiobiological, and plasma protein binding. These three things may affect the drug distribution. So, for example, physiochemical properties, the lipophilicity, which is the drug binding to the lipophilic, which is they love fat actually. The molecular size. So it depends on the molecular size that may act or not acting to the area to the targeted area. The ionization, the pKa. So for physiological factors, blood flow to the tissue, capillary permeability, and tissue binding. Blood flow, like for example, if a patient has dehydration, so they may affect the blood distribution. The capillary permeability. So we have three different type of capillary permeability. We will speak about it later. The tissue binding, we will explain more about it. Plasma protein binding, albumin alpha-1 acid glycoprotein, and warfarin and phenytoin. So we'll speak about and explain about this plasma protein binding more in the next slides. So physiochemical properties of the drug. What is lipophilicity? Refers to the affinity of the drug for lipid, which is fat, environments compared to aqueous water, which is aqueous means water. Environments, it's often quantified using the Parthian the log B actually, which measures by the ratio of drug concentration in octanol, a lipid-like solvent, to the concentration in water. So how does that impact to the distribution? Lipophilic drug can accumulate in fatty tissue because it's love fat, so directly will accumulate to fatty tissue, leading to a larger volume of distribution. This can prolong to the drug action, but may also increase the risk of toxicity. Second, the molecular size refers to the molecular weight and dimension of drug molecule. Large molecules may have more complex structure and be less permeable through the biological membrane. So, in a basic word, if the molecules have a large in size, so this may affect the permeability to the biological membrane. So, yes, there is an example in the next slides. So physiochemical properties of the drug. Ionization, yes, refers to the drug which drug exists in an ionized charged versus non-ionized, which is in a neutral form, which is influenced by the drug pKa, the pH at which half of the drug ionized. How does that impact? The ionization state can affect the distribution of the drug across the biological membrane, including the blood-brain barrier, the BBB, and the placental barrier, which is the place the embryo grow and get the nutrients and supplements, the food from the mother. Sorry?
Ionized drug, polar drug, can be easily excreted from our body, or non-ionized one is easily excreted? Which one? Non-ionized or ionized one?
No, the ionized one can easily excreted from the body.
Yes.
So, physiological factors. So, in the conclusion of this is like more explanation. So, for the blood flow, the circulatory system moves medication through the bloodstream. We all already know about that. But so in some patients, as I mentioned before, problems like dehydration, blocked or narrowed vessels, and heart failure can slow the blood flow, which can affect the blood distribution. For example, blocked vessels from atherosclerosis can prevent antibiotics from reaching the infection. Tissue binding. Distribution happens fastest in organs which allot in blood flow, like the lungs, kidney, liver, and brain. It is slower in the area with less blood flow, like fat. However, lipophilic, the fat-loving drugs tend to collect more in fat tissues, especially the obese individuals and patients. So here the one of the physiological factors, the capillary permeability. We have three different types of capillary: continuous, fenestrated, and discontinuous capillary. So this is the structure of the capillary, and the example here, this is in nervous system and muscle. This is for the glomerular and gut mucosa, and the discontinuous in liver and membrane, in the liver and membrane. So for each capillary has different permeability. For example, here the lumina and the nucleus of endothelial cell, the intracellular basement membrane. So for each one of these, the permeability of the drug is different, because here, as we can see here, the intracell can distribute is different than the other. So what is volume of distribution? The volume of distribution shows how much drug stays in the blood versus moves into the tissue. It is a constant that compares the total drug amount in the body to its level in the blood at certain time. So we have a drug, and how much the drug stay in the blood versus and how much the time takes to move into tissues. So and we have the equation of volume distribution. Amount of the drug in the body in milligram or in different measure, plasma so like the amount of drug over the plasma concentration of the drug in milligram per liter, or in different like measure. Can be milligram and gram, depends on the situation, or nanomilligram. So what is low volume of distribution? Typically less than 0.3 liter per kilogram. Indicates that the drug is primarily confined to the plasma and extracellular fluids. This suggests limited distribution into the body tissues. On the other hand, high volume distribution greater than 1 liter per kilogram indicates that the drug extensively distributed into the body tissue, including fat and muscle. This suggests that the drug is not confined to the plasma. So we have here, this is the table of like more explanation. The volume size, volume of distribution size, low volume, where the drug stays, blood plasma. High volume, where the drug stays mainly in tissues and cells. Example of the drugs, heparin, so because of anticoagulant, so definitely will stay in the blood plasma. And chloroquine, this is for the anti-malarial medication used to treat the malaria. Meaning the drug stay in the blood flow, of course, and for the high volume, the chloroquine moves into tissue and stored in the fat. What? This is a mistake. So special compartments, this is supposed to be special compartments, but I forgot to edit it. So special compartments. We have a central nervous system. This is how the drug distributed in the central nervous system, including the brain and spinal cord. And the implication, placenta. Okay. So what is how the special compartments and the drug distribution in the central nervous system? The CNS, the central nervous system, includes the brain and spinal cord. The BBB, the blood-brain barrier, is a selective barrier that protects the brain from potentially harmful substance while allowing the essential nutrients to pass through. So this is what the video says. Because of the blood-brain barrier protecting the brain from a harmful substance or any other foreign bodies. So for this drug, they give them such as a passport to pass through the BBB. What is that passport? It's the formula of the drug should be lipophilic, or having a specific transport mechanism can be penetrated to the BBB. So an example of CNS antidepressant, for example, diazepam, forget the drug name, and anesthetics. Drugs that hydrophilic or highly protein bounding may limited access to the CNS, affecting their therapeutic efficacy in treatment and neurological condition. So placenta is a unique organ that facilitates nutrients and gas exchange between the mother and the fetus. It also serves as a barrier to some drugs. Many drugs can cross the placenta, potentially affecting fetal development. The degree of transfer depends on how the drug physiochemical properties, for example, the lipophilicity and molecular size. Understanding placental transfer is crucial for managing medication using during pregnancy to avoid teratogenic effects. So we have here the redistribution. So what is redistribution? When the drug distributed into the body when the drug moves from one compartment to the tissue into the body to other after it has been distributed. This phenomenon is particularly important in pharmacokinetics. Why? It can significantly influence the duration of drug action and overall therapeutic effect. So can increase the drug action when it redistributed. So redistribution occurs when drug move from area of high concentration, such as bloodstream or certain tissue, to area of low concentration, for example, that other tissues. So we have factors may affect the drug redistribution. Lipophilic drugs, tissue protein binding. Lipophilic tend to redistribute more readily into fatty tissue, while hydrophilic drugs may remain into the blood or extracellular fluid. Tissue perfusion. Tissue with higher blood flow, such as liver, kidney, and brain, will receive the drug more quickly than the other tissues, affecting the initial distribution and subsequent redistribution. Protein binding. Drugs that are highly bound to plasma protein may have a limited redistribution until they are released from thin spine sites. So I have a question here. What is the relation between Michael Jackson and propofol? Do you know?
He died because of this.
Eh?
Maybe he died because of this.
Oh, yes. Yes. So, example of drug redistribution with propofol. So propofol and drug redistribution, easy example. What happens when you give propofol, rapid IV injection? A drug enters the bloodstream because it's IV. Because propofol is highly lipophilic, it quickly crosses the blood-brain, causes a continuous and that affecting the brain. This lead to rapid onset anesthesia within approximately around 30 seconds, but the brain highly perfused and relatively small in volume. Then what's happened? After a few minutes, propofol begins to redistribute to less perfused and larger tissues like muscle and fats. As the concentration in the brain drops, the anesthetic effect wears off. So the effect's off, even though the total amount of drug, the body hasn't changed much yet.
There is a one thing, it starts with the rapid onset of action. That means it bypasses the first pass metabolism. If you remember that, if we take it intravenously or if we do the intravenous infusion or injection, we cannot give it to the patient rapidly because we will see the toxicity. Because why? 100% of bioavailability, we can
Yes.
get it.
Exactly.
It's very dangerous. So we have to be careful when we are giving to the patient rapid IV bolus or infusion. We have to monitor every time, especially the normotherapeutic index drug.
Exactly.
And that one.
This is how actually Michael Jackson did. Yes, they give them directly.
Distribution and also the intravenous administration.
Exactly.
So the administration is also important.
Yes. Okay. So clinical impact.
I like also your example.
Thank you. A loading dose is initial. This is a loading dose. A loading dose is initial higher dose of the drug given to rapidly achieve the desired therapeutic concentration in the bloodstream. This approach is particularly useful for drugs with a long half-life or that does require immediate therapeutic effect. So in some cases, they give the higher dose to see the effect of the medication on the patient. What is the purpose of loading doses? Rapid therapeutic effect. Loading doses used quickly to reach the target plasma concentration, especially in the situation where immediate drug action in critical, for example, in acute condition like infection, seizures, or cardiac arrhythmias. Overcoming distribution delays. For drugs that with a large volume of distribution, it may take a long time to reach therapeutic levels through the maintenance dosing dosing alone. A loading dose helps to bypass this delay. So when we give the loading dose, so the delay to help that to prevent that delay. Factors may affect the loading dose. Volume of distribution, desired therapeutic concentration, patient factors. So for example, for volume of distribution, with a large volume of distribution indicates that drug is widely distributed in tissue, necessitating a higher loading dose to achieve the desired plasma concentration. Desired therapeutic concentration, the target concentration will vary based on drug therapeutic range and the condition of being treated. Patient factors. For different patients and individuals, characteristics such as age, weight, organ function, and comparatites that can influence the loading dose. Example of loading doses, digoxin used to treat the heart failure and arterial fibrillation, a loading dose is often given quickly to achieve therapeutic level, followed by maintenance doses. Antibiotics. Certain antibiotics, such as vancomycin, may require the loading dose to rapidly achieve effective concentration, especially in severe conditions. So in some conditions, we have to give the loading dose to that patient. Antipilapitics. Medications like phenytoimine may give as a loading doses to control the seizures quickly. Drug interaction and distribution. Plasma protein binding and displacement. So what does that mean? Many drugs bind to plasma protein like albumin. Okay, when bound, the drug is inactive, cannot cross membrane or be metabolized, not filterized by kidney, acts as a receiver of drug in the bloodstream. Only the free unbound drugs is active and can exert in pharmacological effect. Displacement. If two drugs that bind in the same plasma protein site are given together, one drug may displace from the another site of binding. This leads to increase in the free active concentration of displaced drug, result to increase pharmacologic effect or toxicity. So here we have in non-steroidal anti-inflammatory drugs and warfarin. Warfarin is highly protein bound, like 99%, and it's non-steroidal anti-inflammatory drugs like ibuprofen are also protein bound. When they both be taken, NSAIDs can displace warfarin from albumin. This increase free warfarin levels temporarily, lead to increased anticoagulant effect that cause higher bleeding risk. So emerging concept, this is how we can increase the drug distribution in the body. So as this is the hype of today, the nanoparticles. Nanoparticle delivery system enhance the pharmacokinetics by improving drug solubility, stability, and targeting capabilities. These systems can facilitate localized drug release, increase bioavailability, and reduce systemic toxicity, making them promising tools in modern therapeutics. So how the nanoparticle delivery system improve the drug distribution? Improve drug solubility and stability, targeted drug delivery, enhance the permeability and retention effect, controlled release mechanisms. So how for example, nowadays in cancer treatment, they are trying to reach the effective cell, the cancer cell, without affecting the other organs. For example, when the patient receives chemotherapy that may cause the damage in his body. So by the nanoparticles drug delivery system that can just target the exact cell. So in conclusion, drug distribution is a key determinant of drug efficacy, toxicity, and dosing. Factors like lipophilicity, protein binding, tissue permeability, and blood flow all influence how and where the drug moves in the body. Understanding the concept like volume of distribution, redistribution, plasma protein displacement helps clinicals predict drug behavior, avoid adverse effect, and optimize the therapy. Ultimately, the right drug in the wrong place or in too much of the right place can mean the difference between cure and complications. Lastly, knowing where the drug goes is just as important as knowing what it does. And thank you for listening. And if you have any question, we are ready to answer you.
Please send it to me.
Sure. Sorry?
First presentation.
Okay, sure. By email or WhatsApp, which one you prefer? Okay. Okay, thank you so much for listening.